Hi, I'm John Nordt. I'm an orthopedic surgeon, and I do mostly all spine surgery now the last 7 or 8 years. I'm from Miami originally. I grew up here, trained in Colorado, Springfield, Illinois, Maryland. Was on staff at the University of Miami, and then I ended up coming in private practice in 1983 in the Coral Gables area. And my love is spine and fixing people whether they need surgery or not. I'm going to talk about a subject today, basically back braces and understanding conceptually. There's some seats up here if you all want to sit down. Come on up. There's one here too and one over next to Mrs. Lynn. The concept of why back braces are needed is somewhat lost and hazy a little bit in the last 10 or 15 years with the advent of a lot of surgical procedures and the advent of the training programs for orthopedic surgeons. What happens in a lot of training programs is money is not made and papers are not written unless surgery is done. And so therefore non-operative care has sort of fallen by the wayside, but it's a very necessary part of my care and for other people's care. A lot of orthopedists henceforth are not really trained well in this, and sometimes they don't even understand. So it's kind of everybody's in the dark to some extent. How many of you had any training about braces at all when you came through your training programs? Anybody here have any? There's just a few, and that's basically what I expected. And I think the educational aspect of braces is very important to understand, so you're not caught, oh my gosh, what am I supposed to do with this? You know, and how do I put it on? And the answer is you just tend to walk away. And I know how that works because anybody who's in a position without a lot of knowledge will either go seek help or go on to things they can fix. So anyway, I do only spine surgery, mostly about 95% lower back surgery. The spine itself is a very interesting, despite the fact that they want you to assign your site, because there's only one, there's no left, there's no right, it's right in the middle. And it's a core structure. It's a core structure to help hold your rest of you up. The ribs attached to it, the neck swivels on the cervical spine. But we're going to talk today about braces that have to do with the thoracic and the lumbar spine. And these braces basically are designed depending on where the problem lies. Now, back braces and abdominal corsets, and I'm going to mention those for a minute. A lot of people will wear an abdominal corset. And that's good for a short-term use, for maybe a week or two, for a muscle strain. But abdominal corsets, in the long run, will make your muscles weaker. And so therefore we don't really encourage them for any long-term length of time unless you're 85 or 90 years of age or so infirm that you cannot get around without it. And that's some judicious use needs to be done. A lot of doctors, and I hate to say this, non-orthopedists will sell you a brace in their office, and there's a marketing issue there, and I have a problem with that because I don't think the patients really do need it. The hallmark of bracing physiologically is your stomach and back muscles. And stomach and back muscles are strong and they help hold your spine up. If you've got a defect in your spine, whatever it is, fracture, degenerative disc, whatever, stopping that motion of the spine, the twisting, the flexion, extension, and the lateral bending, that will reduce the amount of cause of muscle spasm. And the bottom line is that if you can strengthen the muscle and reduce spasm with an anti-inflammatory medication and irritation, then you can get away without a brace. Come on in if you want. We've got a couple seats up here. One of the things that I use a brace for is for fractures. And fractures, good morning. One of the things I use a brace for is for fractures. And if you have a fracture, depending on what the location is where the brace is more effective. And if you have somebody who stands up here, here's your pelvis, your hip, and your leg. If you stand up, this is your neck above here. This is your thoracic spine where the ribs are, okay? And this is the lumbar spine, of which there are 5 lumbar vertebrae. Now, what happens when you bend over and touch your toes, you can bend through your hip, and you can also bend through your waist. Now, as you know, the ribs hold your chest together and keep your thoracic spine from moving too much. But you have a hinge point right here. And that's a T12 or L1, okay? And this is the area where most fractures occur, at T12, L1. That's where most of the flexibility is. If you're elderly and you sit down hard and you flex forward, the bone itself can crush down and become quite narrow, and it causes an angulation of the spine. So hence we want to prevent that from happening. Now, one of the things that happens is you can have a fracture in the thoracic spine, you can have one in the lumbar spine, or in the transitional area. And depending on which area the fracture occurs has a great deal to do with what kind of brace we use. I'm going to do with the most simplest brace we have today, and I've got some examples here I'll show you. It's called a Jewett Brace. And the Jewett Brace is one type of brace that does exactly the same thing as about 3 or 4 others. What it does, if you have a fracture here, what it does is it puts a pad here, and a pad here, and a pad down here. And what that does is you put your finger and a pencil, you have a 3-point fixation that keeps it from bending forward. And if this exerts a force in the back where the fracture is, it exerts a force in the sternum to keep you from flexing forward, and over the pubis to keep you stabilized here. And it's a very, very minor amount of framework to hold the whole thing together. Okay? And this basically has a little bit of a brace to hold it in place, and it keeps you erect. Now, what happens, and this is something that a lot of people complain to me, my patients, and compliance with an older person is difficult. It really is. There's no question about it. Henceforth, these braces, even by orthopedists, were never applied a lot, never used a lot. What happens to these people, and I'm going to digress management-wise for a second, these people who have fractures will sometimes be sent by their internist, family practitioner, to a pain management person. Now, what does that do? That just manages the pain. It doesn't take care of the problem. That's like having a noisy muffler and putting earplugs in. It doesn't solve the problem. And so if you send them to pain management, one of the things that happens with these people is they have an ileus, which means their bowels stop working for a day or two, because bleeding occurs retroperitoneally behind the vertebra. And that stops the bowels from working for a day or two. A lot of these people will come in the hospital fresh from the emergency room, they're belching a lot. They're burping a lot. And the reason they're burping is it's not going through. Everybody who swallows liquids or food swallows a little bit of air. And if that doesn't go through, it comes back out. And so an ileus occurs. You have pain. And this is managed with narcotics. And what does narcotics do? Promotes an ileus. So it's really not really a good solution. But a little knowledge goes a long way. And if you have immobilization of that fracture with a back brace, then you can stop the ileus. My method of treatment from the emergency room would be to admit people, put an IV in them, keep them NPO. Overnight, we get the brace fitted, get them up with a brace the next day. Generally, if you get it fairly quickly, you're all right. One of the problems is in the emergency room, the textbooks in the emergency room, textbooks for the emergency room doctors, and I've talked to many of them, mentions this type of compression fracture, a T12, L1, or T11 compression fracture, not going to cause any neurological compromise. You're not going to be paralyzed, no bowel or bladder problems. And it's just a management of pain. And that's all it says. It doesn't talk about an ileus. There are people that have died with a perforated viscus for the dilated GI tract, and nobody understood why. And they died of sepsis because of that. And that's happened in this town. And that was less than 10 years ago. But the bottom line is if we can go ahead and treat this ileus by immobilizing the fracture, minimizing the fracture motion and the pain, and minimizing the bleeding, then we can fix it. Now, I'm going to talk at the end about something else called the kyphoplasty, which has really been a help, because that is the next step in treating these people, because this has become a neglected fracture by both the physicians and by understanding of other paramedical people. And this is the bottom line. This unfortunately is the case. Fortunately, the kyphoplasty and the vertebroplasty were invented to take care of this in a kind of an operative way, which got the physicians interested again. So what happens is these physicians now are able to manage these people fairly well. And I'll talk about that at the end because this is about braces today. Anyway, so you have a T12 or L1 fracture, and you put them in a Jewett brace. And I'm going to write that down for you. And it was put together as a guy up in Orlando about 50, 60 years ago put this together. And it's a Jewett brace. It's very simple. How many of you ever had a cast on? So a cast is on and immobilizes your either wrist sprain or ankle sprain or fracture for a period of 4 to 6 weeks, more or less, to allow it to heal. Well, if it's allowed to heal over that period of time, then it's as good as new. You strengthen the muscles and everything else. So if you have a fracture and you put a Jewett brace on, what do you think about taking it off to get dressed? What about not putting it on until you get out of bed, get dressed, bend over, put your shoes on, and then put the brace on? My point is taken, I think. You understand the point. This needs to be on at all times. It's like a cast. Years ago, before this was available, we used to put people in a cast. And the cast could not be removed for hygiene, for cleansing purposes, anything. And it became very hot, especially in our climate down here, especially in the summertime. Hence, the T-shirt is put underneath it, which is what one of your comments, one of the handouts shows on the TLSO. But the bottom line is that these people need to be instructed and helped with it. And just to have you understand the concept behind why we're doing it and how we need to do it. And this brace needs to be on. Again, you can see this brace has a pad in the back. This is actually, this is a different type of brace than I'm used to because this has a thing around the pelvis. I personally like a pad on the top and the bottom right against the pubis. Now, yeah, that's okay. That's just to show it's not exactly what I normally use. But this brace, now, those of you that have treated people with braces, the Jewett brace is on, or a brace, and this is going to be true of all of them, and we're going to go through some more here in just a minute. When people sit down and they put weight on their buttocks, what happens? They tend to fold forward a little bit, right? Now what happens then? That pushes this up into their chin, and they say, oh my gosh, the brace is too long. And so you call the brace guy, and they try to shorten it a little bit. And then they shorten the bottom one, and pretty soon you have no three-point fixation anymore. You don't have that concept. So the idea behind this to help you all make the patient comfortable in a brace is have them recline slightly, put a pillow back behind their back to allow them to extend their shoulders. The reason this brace is in place here is to make sure they lean away from the pad. It's not something to lean on. It's not a crutch. A lot of old ladies will lean against it and they'll get a skin rash. Oh, hit my microphone. No wonder you jumped. Anyway, but this brace will basically rub against it if you put pressure there. And so people with fragile skin, which we see a lot of these days, will have a problem wearing this. And so that's why the T-shirt is placed there. But the idea is to strengthen the back muscles, lean away from it, use it as a guide, not as a crutch. And if you lean forward and try to flex forward, then this thing gets pushed up into the chin area and they have trouble swallowing. And then that'll be a recurrent theme through the rest of the braces we're going to talk about. So that's a Jewett brace. Do you have any questions? Anybody any questions about this?
Can I just make one comment about it, just so that everybody knows? The Velcro in the back is not how you remove that brace. There is a little snap on the side.
Right here.
To show them that's how you remove it, because when the
It's adjusted properly.
exactly
Right.
by Thomas or whoever comes in and initially applies that, so that Velcro is set to measure appropriately for that particular patient. So the removal is on the side, not by the Velcro in the back.
I've never seen one with Velcro in the back, so thank you for mentioning that. But they used to have a clip here, then they used to have Velcro here, which didn't work, and now they have a canvas clip here for they usually use for boats. But it's real easy to open. You just lift it. In fact, there's a little letters here. It says lift the dot, okay? And if you can read that, it just takes a second and it pops it right off. But this is very carefully positioned, so it holds them upright. Thank you for mentioning that. Any other questions about the Jewett brace or the three-point fixation brace, which is for the middle three fractures? a little understanding of how long, what the complications are. How long does this take to heal a fracture if you're going to wear it? Anybody have any idea? 3 months? No, it takes 3 months. It's 3 months.
About their age, some people is getting older kids take longer.
Well, it's interesting. That's one thing about it might be if the compliance is poor, but generally speaking, if you're starving and you have lousy bone, fractures will still heal at the same rate. That is an evolutionary thing that came along back the last 10,000 years or 20,000 years, because you mobilize calcium from the rest of your skeleton, because if you can't heal a bone, you can't hunt for food. If you can't hunt for food, you're going to die. So those people that heal the bones quickly ended up being able to survive and carry on genetically. So it's a human and an animal trait to heal fairly quickly, but 3 months is minimum. Unfortunately, the pressures on the vertebra are great at that level, especially when you're sitting. This is a brace that is used. This is called a Taylor Knight brace. And the difference here is this is and I'm going to talk about two different braces here, because if you get rid of the top part of it, it's called a chairback brace. And I'm going to talk about that first. If you get rid of, just forget about the top, and the part just comes around here. That's a brace to support the lumbar vertebra. Now, that's probably L2 to 3, L4, L5, okay? Now, if you'll notice, in the lumbar vertebra are hyperextended like this, whereas the thoracic vertebra are like this. So most of the weight is not on the vertebral body here. It's on the posterior elements, on the back side of the vertebra. So therefore, the compression of this vertebra is less. Up here, with the flexion that occurs, the compression moves forward on the vertebra and tends to deform that vertebra. So a chairback brace that fits the bottom is there to immobilize the bottom lumbar vertebra and keep you from flexing it and hold it still. And it's an excellent brace, a chairback brace is, to hold people in place. Now that's used also for burst fractures and other types of fractures of the lumbar spine, as long as it doesn't need surgery and doesn't have a neurological problem. I'm going to go on and talk about the Taylor Knight brace now, which is basically a chairback brace with two pieces that come up. Now, let me start this thing all over again. If we have our little figure here, your pelvis is here, your hip, and your legs here. And if we have our thoracic spine here, our shoulders are here, we can't put a brace on to hold our shoulders together here by using the concept of a Jewett brace. That cannot be held in place that way. So we have to get control of the shoulders. And in order to get control of the shoulders, we got to go over the top to hold it. So this part of this brace comes up from the front, part of it comes up from the back, and this comes around the shoulder here and pulls this way to help hold the shoulder back. And that's for a fracture of anywhere T2, T3, 4, 5, all the way to probably T11 or 12, the thoracic spine fracture. And this essentially comes around the shoulders and helps hold it back. How many are familiar with a clavicle splint for a fractured clavicle? The fractured clavicle splint helps hold the figure 8 splint, pull in the back, and helps hold the shoulder back. The Taylor Knight brace does the same. Again, it's there for a fracture, it's helped to relieve pain, and it's helped to prevent any further deformity of that fracture, which can occur. As you recall, again, the ribs are here, and the ribs act as a brace, because if a rib comes off of a vertebra, it can't get any closer than the ribs are. So it does brace to some extent, and there's a very high rate of healing in these fractures with or without a brace. So why are we using a brace? Well, the reason for using a brace is, number one, pain relief, which is significant, and number two, more importantly, prevent further deformity. You can get deformity of a fracture here, and you can get several fractures that are wedge-shaped. And what does that do? That bends the spine over. And what's in front of the spine underneath the ribs? The lungs. Now, if the lungs are compressed, that compromises your ability to take a deep breath. Now, we know that one compression fracture in the thoracic spine will decrease your functional vital capacity by 9%. Functional vital capacity is, forced vital capacity rather, is the ability to expire in 1 second to expel most of the air. And most people is 4 to 6 liters, 3 to 6 liters, real quick. And that's a function of your lung. Now, over 70 years of age, most people have lost 50% of that. Older people don't have the resilience to exercise over 70. And so therefore, you've already lost 50%. Now, if you have one fracture and you've lost 9% of your forced vital capacity, then you've lost a significant amount. So if we can prevent the deformity by using a brace, then that will help that patient. And so that's why it's so important. So pain relief and deformity and the secondary physiological aspects of that are very important. If you have several different fractures here, I have people that have ribs sit right down on top of their iliac crest because they're so folded over. Then they have pain with their ribs rubbing. And you know, you've seen the short little old ladies that come in, and some men too, who live long enough to have the fractures. They end up having a lot of discomfort, and there's not much you can do for them once the fracture is deformed and once it's healed in that position. So the idea is to try to prevent them. So we're all focused towards getting this patient out of the hospital in a quality of life that we want to be optimized as much as possible. Because that's why we're all here. So a talar night brace is to hold the shoulders back and prevent deformity. Now the last brace that we have here, the last brace is a TLSO, and that stands for thoracic, lumbar, sacral orthosis. Now you can have an LSO, a lumbar sacral orthosis, which can do a similar job to the chair back brace, which you remember is without the top part. And this is a little more comfortable for people. In our hot climate down here, this gets to be very uncomfortable. It gets sweaty and people don't like it, et cetera, and then consequently don't wear it. And that's a problem. But this is necessary in certain instances. I use this brace very rarely, except more commonly use it with a thigh piece. And I usually have a metal rod coming down with a hinge and a thigh piece that fits on the thigh. Now think about it for just a second. If we have a our stick figure here, this is thoracic, this is lumbar, this is pelvis, and this is your femur. If we have a brace on holding the thoracic and lumbar spine together, and we go right down to maybe include the pelvis, our last vertebra is here, okay? Now, if we can immobilize from here to here, that focuses the motion on that last vertebra. So in a sense, without the thoracic piece, I'd rather have no brace at all. Because if you just put this on, it just focuses motion on the bottom vertebra. So therefore, we connect a rod here with a hinge point, and we have a thigh piece attached to it with a rod with a hinge on it. Now that hinge may be baffling to some of you who are not mechanically inclined, but it's a hinge that has a little drop lock piece in it that once you stand up, it's supposed to click into place, and so it's stiff. And it's supposed to be stiff because that prevents twisting, rotation, which is the worst thing that could happen to people with back problems, is twisting. So this will hold it in place. However, when you sit down, you need to pop it up, and then the hinge will flex, and that's what it's designed to do. Before our advent of new materials and new braces, back when I was in training back in the 70s, We used to put people in a body cast. It's called a pantaloon cast. And you have a body cast, you put it on, and you have a thigh piece down one side. And people would sit in a chair like this. And it was very uncomfortable. It's just like, you know, if you fly around on airplanes, you know what it's like to take a vacation in a car. You know, you don't know how good you have it until, you know, you do that. And most people don't realize how good they have it wearing a brace such as the TLSO with a drop lock hinge and a thigh piece. This drop lock hinge basically allows much more mobility and much more facilitates activities of daily living like sitting in a chair and eating and things like that. So this back brace with the drop lock hinge to substitute for the pantaloon cast or the thigh piece with the body cast is really a great boon and a great help, and it's been a benefit for the last 20 years. A lot of surgeons think that the back brace with a drop lock hinge and a thigh piece is not really worthwhile, and the reason they say that, nothing has been published, but something was published in the early 70s, and just about 6 months ago an excellent article was written using videography, video radiographic images of flexion extension with and without braces on to show the motion of the lumbar spine, how it's decreased significantly with this type of a brace. And someone finally came, like I said, these papers are few and far between because they don't make a lot of money on them. There's not a lot of operations to be done. You're not buying hardware from a company that's marking it up 500%. You know, and the hospital's not making money. So what's the impetus? It's good patient care, which has to come back eventually, sooner or later. So the drop lock hinge and a thigh piece is attached to the TLSO down one side or the other. And in my particular patients, I use this brace for post-operative, pre-operative diagnostic ability and post-operative care. If I have a degenerative disc, a vertebra here, and a degenerative disc here, and a vertebra here, and a degenerative disc here, and a vertebra here, and these two are painful, and I want to decide whether or not these discs are the pain generators. In other words, are these causing the pain? Not a herniated disc, not spinal stenosis, not anything like that. This is one of the more difficult diagnoses to make. We do discograms, but also I show the patient, I can relieve your pain. And you put the brace on, if this is truly where the pain's coming from, then the disc itself, the pain itself will be reduced by about 50% by and large. I put it on for a week or two. I go ahead and do a discogram, which is a provocative test, and then eventually they are in agreement to do the surgeries if we prove it with this, and we usually do. So I use the brace as a diagnostic procedure, and then post-operatively, if I put screws and rods in here and connect them and fuse the spine, I use the brace afterwards for 6 or 8 weeks to reduce the pain medication needs of the patient, which helps facilitate mentation. It improves their ability to get around. They're not as sleepy. They're not as unresponsive, especially when you're a little older. And so these braces can be used afterwards, and this is my intention, to reduce the pain of the muscle envelope. When I operate on a spine, I make an incision in the back, sometimes in the front also, but the muscles are swollen and they're tender back there, and they hurt. And so therefore, for the first 2 or 3 days, you know, you need as much narcotics as is ordered. But the bottom line is once you get up and move around, you feel secure with this brace on. And a lot of you who have been here for a while know that's the case. So the brace needs to be on, usually the 3rd or 4th post-operative day when they can tolerate it. And generally, I try to get them to put the brace on before the surgery, and 9 times out of 10 we do achieve that. So they're comfortable with the brace. It's not a foreign object. It's not something that they have to contend with along with the surgery, the medication, and the catheters, and all that other stuff. So a brace is very helpful, and I have them wear it at home for about 6 weeks, and in the last 6 weeks of the 3 months it takes for it to fuse, I go ahead and I help people. I have people wear it just outside the house, leave it off in the house. So it protects them when they're outside in their social situation. So that's a TLSO. Is there any questions about the TLSO? You've all had some experience with this or no? Okay. One of the things that we have also, and I mentioned, I'm leaving this up here because I want to talk about some of the new breakthroughs that have happened in management of compression fractures. And the compression fractures are are the fractures we've just discussed in the thoracic, thoracolumbar, and lumbar spine. And one of the things is the kyphoplasty. Now, back in the late 80s, vertebroplasty came into being, and it's injection of cement under local anesthesia into the vertebral body. And just like cement, like grout, it's the same cement you would use for a hip or a knee, a total hip or a total knee. And it stops the fracture from moving. So if you have a fractured vertebra, it's like this. And you inject cement in here, that keeps it from hurting. It internally splints it. But you've got an angle there that's significant. And so that was great for relief of pain. In the last 4 years, you've been seeing these kyphoplasties scheduled. And a kyphoplasty goes in under local anesthesia and puts a balloon in here, expands this, so this vertebra is now expanded. Correct that angle. You can decrease the chances of pulmonary problems, respiratory problems, and you can correct that angle, and you can fix it by putting cement in here with this balloon. And this is something that has developed in the last 4 years, which I think is really fabulous from a patient care standpoint, because there's very little risk. It's done under general anesthesia, and they get better. It's like a 98% success rate. It's amazing. In fact, my problem is some people, well, my back still hurts down here. Well, I didn't fix it down there. You know, it's just one of these things that the expectations are greater than the realization. But you did fix the fracture there. I have always said that these compression fractures, it's a neglected fracture for the reasons I mentioned at the beginning of the talk. A neglected fracture is something that people don't understand. It goes to the pain management guys. It doesn't go to the orthopedists. Many orthopedists are not trained to deal with it, especially a lot of the younger ones, or they just don't want to. The front desk at the office says, well, we don't take care of back problems, period. And so therefore that back patient is now have to go somewhere else. Many times the emergency room will have a back fracture and they'll send it, well, they won't call the orthopedist, they'll send them to the orthopedist. They'll call it the next day, we can't see you for 3 weeks. That's what happens. That's the reality, unfortunately. And so they can't be seen for 3 weeks, so where do they have to seek some care? They're hurting. They're really hurting badly. They should have been admitted overnight, generally speaking, discharged as an overnight 23-hour stay, discharged the next day. But a lot of people don't understand it. So for lack of understanding, it's become a neglected fracture. And so therefore, fortunately, kyphoplasty has been, now, and the development of kyphoplasty has been superseding vertebroplasty and will do so from here on out, I think, as the better procedure. Once this is known, I think it's going to be like an outpatient procedure, like it is now, only done in outpatient centers, and it's going to probably get rid of a lot of the braces that we need. How the fractures take 3 months to heal. If you wait 6 weeks before a kyphoplasty is done, then the chances of reducing that fracture becomes less. However, if someone has back pain related to that fracture even a year later, it can still be fixed because there's a reason. The fracture generally is not healed. Those of you that wore casts years ago, that you raised your hands earlier, you wore a cast if you wore it for a fracture. If you didn't wear the cast, then you would end up with either a malunion, healed in an abnormal position to where your arm doesn't work, your leg doesn't work well, or a non-union, which means that it never healed. Then you have to have an operation to fix it. And you end up with a non-union of this fracture, in many instances, a year later, if the pain persists in an elderly person. So I'd like to answer some questions, if anybody has any, on this, some burning questions that you've been thinking about all through New Year's, and we're holding for this meeting.
Well, I'm just amazed that you can help them a year later, because that's what I was going to ask, was people that, you know, maybe fell and didn't seek help or didn't realize they had a fracture.
You can have a fracture. I mean, I'm just going to draw a big picture here. And you can have what we call Crumbles disease. This is a radiological term, and when a fracture occurs in an elderly person, the fracture usually occurs through here and through here. And all this bone here is very fragile and almost non-existent. So as they get up and move, you get these end plates here and here move up and down, up and down, up and down. And you have osteonecrosis of the vertebral body at this level here. And so you have an end plate here and an end plate here. And on x-ray, you have a dark line right through there, and you can see it a year later. It's on plain x-rays and very clearly visible on an MRI or a CAT scan. And with flexion extension, you can see them moving. And so this is one reason why people can have this fixed. So you can go ahead and do the vertebroplasty and fix it. And I've done a number of these. It's not the most common, but it's one of the common reasons why a year later you can still fix it. The advertisement and the marketing for these procedures says, well, if you do not have a fracture, if you have a fracture past 3 months, we can't help you. That's the criteria, and so the doctors never send them, and that's not the case. And just the same, back pain can be fixed no matter what it is. It doesn't have to be this as the etiology. So,
Are we educating our ER physicians?
I've tried at times. It's difficult to do that. With this, I'd be happy to do that. I think it's important to do that. I think
Can you
this.
restate the question?
Oh, thank you very much. I was told earlier I had the microphone, but are we educating our ER physicians on this type of bracing and fractures and stuff? And I don't know. I'd like to do that, and that's something that we could explore because I think it would help from a patient care standpoint. It's a very good question. The ER physicians that I've spoken with who are no longer here a couple years ago, they said their textbooks only relate to the emergency care of the fracture, and that's it. The long-term nature of the fracture, the sequelae, the problems that occur, the management of it is unknown to them. And there's a little bit of a disconnect there. So I think it's a very good start, and I think I might even explore that. So thank you. Yes, Helen.
The education as far as applying the brace, when the tech comes out, is the nursing involved? Should they be there the same time the tech is? What's your recommendation?
Well, I think the tech that I use is Thomas Dowell, whom you all know well, I think. And he's a very good guy. He will come out. He will take the time. I think you all have heard a talk by him. Some of you have heard it in December, about a week or so ago, and I heard it was a very good talk, and I may have been somewhat repetitious. But when he comes by, he would be happy to show the nurses that are there that are interested, and then they could pass that on to the next nurse, the next shift. One of the frustrating things I have is people are sometimes in such a rush to go that they end up not giving all the report, and one of them is how to put a brace on correctly. I've read this handout, by the way, and the handout shows how to put the brace on in bed. Now, if you have a spine fusion, such as I do, which is where the lion's share of these TLSOs with drop lock hinge and thigh pieces are applied, you don't need the brace to get out of bed because the brace, the fusion is fixed with screws and rods. But you put the brace on for pain relief, for quality of life, reduction of narcotic usage, and to train the patient how to do this so they can go home with it. Now, if the patient doesn't have somebody at home necessarily to help put the brace on in bed as it's described here, another way to do it is to put the brace on in a chair. And so if you put the brace on in a chair, you just leave it just like this, with the thigh piece down and the hinge flexed, and all you got to do is sit in it. And then the patient can actually bring this up and put it around in front of them. And they can tighten it, and they sit into the thigh piece. They can fold the other piece around and do it. They can almost do it themselves. Now, this is something that would be helpful to all of you, because then you don't have to do a lot of lifting and moving and all that. And you can teach the patient how to do this in a very organized fashion, so they have, and this is the most important thing I think in my patient care, allowing the patient to regain some control of their life, because this is a problem that most people have when they have surgery. So if you put the brace in a chair, a straight chair, without armrests, it's very, very helpful to for the patient to learn how to do this. And you repeat this once a day or twice a day. The only time the brace should be off, at least for a Jewett brace or a chair back brace, is for taking a shower. And usually you ought to have somebody assisting them doing that. You may not see a chair back brace or a Jewett brace here very much because of the kyphoplasty that is being done and the vertebroplasties. But the Jewett brace, I tell my patients, you step in the shower, you take the Jewett brace off, you take the T-shirt off. Somebody is there, should be there anyway. And you wash down, do not bend over, shower, clean up as much, wash all the soap off, step out, dry off, put the T-shirt on, put the brace on, just like that. I have little old ladies come into my office. They're all dressed to the nines. You know, they have a nice red sweater and they have, you know, pants on and jewelry and the brace is on over all this. And I know darn well they didn't get dressed in bed. They bent over, they put the shoes on. And the bottom line is that the concept, this is not a piece of jewelry. It's not a garment. It's a brace. And it should be on 24/7.
As far as your spinal fusions go, what are we to do about overhead trapezes? Because I've seen them with trapezes and we never used them previously, but what are your recommendations?
I've been using those for 15 years. And the reason I use them is because a lot of patients don't have the abdominal strength to even turn over.
Using what?
Oh, thank you. God. The question is an overhead frame and trapeze to be used or not? And this is something that I do order for my patients, and it's to facilitate people. Some of the people that I operate on are a little heavier than they maybe should be, and so having a trapeze to pick yourself up and roll over because your abdominal and back muscle strength is so poor, or the pain is so great that you can't turn over, I find it to be very helpful for mobilization of the patient and also helps you all.
And it doesn't hurt the instrumentation? that you
No,
put in?
not at all. Not at all. Generally speaking, the instrumentation, you can slip and land on your butt, and the instrumentation is going to hold. Very rarely, I don't think I've ever seen any real injury from the instrumentation with an injury in a fall. I had a lady come in at 6 months one day and rollerblading and landed hard on her butt. She thought it was the end, and I said, no, you just hurt yourself like anybody else would. So it's pretty secure. It's pretty secure. But the brace should be on. Teach them how to put it on at all times. The overhead frame and trapeze, I usually order, and about Ms. Lynn and I go round and round. She tries to get it on, and I try to get it on the beds the night before or before the patient comes back from surgery. And generally, it's a day or two before someone gets around to doing it. So if we could go in that direction, it'd be great, because it's another patient another patient, something to help patients with and help them get better faster. So we've been through the Jewett brace. We've been through the chair back brace, the lumbar sacral orthosis, the TLSO, or thoracolumbar sacral orthosis, which is basically extends up into the chest. And for females, there's a mid pad in here so you don't squash your breasts and everything, because that's uncomfortable. And then the thoracolumbar sacral orthosis with a drop lock hinge and a thigh piece is the last one, which is what I use mostly. So I really appreciate the opportunity of talking to you all. I know it's an effort to get here. Maybe you get a little break from work for a bit, but education is education. So, yes, hi. Excuse me? If you're pregnant. Well, most pregnant women are not 70. The question is, do pregnant women need braces, or how do you put braces on pregnant women? Generally, if you're pregnant, you're under 40. Chances of you having a fracture or something cause that pain from a spine standpoint, a degenerative disc standpoint, is fairly slim. And honestly speaking, I've never put a brace on a pregnant woman, because most of the difficulties they have are either a neurological problem with swelling and retention of fluid, and they have a similar type thing to a herniated disc with leg pain. I've seen the sciatica problem. It goes away, just like a carpal tunnel occurs with pregnant women. And that'll go away once the swelling goes down and the retention of fluid goes away and the baby's delivered. Generally, you want to just control it with very, very mild Tylenol and rest until the baby's delivered, because pregnancy, fortunately, is not a permanent situation. Although in some people I wonder. But But no, I've never used a brace for them because they don't have those degenerative problems. But I think that could be arranged, but I have not seen that in my practice. It's a good question, though. Any other questions? All right. Well, thank you very much.
Thank you.